about acute liver failure. I'll just do a bit of a background about liver disease in general and chronic liver disease particularly, which is clearly what most of us who work with liver disease see most of. It's a big and growing problem. It's currently the 5th largest cause of death in the UK, and it causes death in people who are young. As you can see, the average age is under 60. Mostly it's preventable in that it's due to lifestyle-related causes, either drinking too much, eating too much, or doing things that help you to acquire viral infections. In this part of the world, except in other parts of the world, there's other ways of getting viral hepatitis. But we've definitely seen rates increase in younger people in the last 10 years. And I think anyone who's been working in that time will have seen it coming in through the front door as well. If you look at disease-related mortality, this has increased 6-fold in the last 30 years. It's almost impossible to see someone who works with liver disease give a talk without showing this slide, and even though it's got nothing to do with acute liver failure, I'm going to throw it up there, because while everybody else and anyone who works in any other specialty is succeeding, we are failing, or at least we're not getting the message across. Premature death, so these are people who die under the age of 65, from 1970 up until about 2010, you can see all causes of premature death falling: heart disease, stroke, cancer, chest disease, everything. But liver disease is climbing at a huge rate. Anyway, moving on from that to why I'm talking today. So what is acute liver failure? Well, acute liver failure is acute, it happens quickly, and you get a very rapid deterioration in liver function. It results in what they call altered mentation, or encephalopathy as we call it, and coagulopathy in people who've got otherwise normal livers, or previously normal livers. And this is how the American Association for the Study of Liver Disease defined it 10 years ago now. If you go back to the original definition, somewhat more than 10 years ago, it hasn't really changed. It's about coagulopathy and it's about encephalopathy in people without pre-existing cirrhosis. They've given a 26-week time cut-off, and I'm going to go a bit more into the different timescales for different types of liver disease, which has sort of gone out of vogue because it mostly relates to etiology. The worry about acute liver failure is that it carries a very high morbidity and a very high mortality. And before the days of transplantation, survival was no more than 15%. So it was really a dismal disease. It makes cholangiomas look positively good. Currently it's better than that, it's about 65% short-term survival, but that's using transplantation as an option. So it's been subclassified according to timescale and how it presents. And as I say, these subclassifications are sort of moving out of vogue again. They keep coming and going, mostly because they relate to the different causes of acute liver failure. Hyperacute liver failure is the one you will often see. Typically it's a patient who comes in with a paracetamol overdose, come in a few days afterwards, you probably missed the boat to give them NAC, and within a week you'll go from becoming jaundiced to becoming encephalopathic and probably needing a transplant if you're not going to recover. There's then acute, which is from a week to 4 weeks, and then subacute up to 3 months. By the time you get beyond 6 months, it's looking more like chronic liver disease, and that's mostly our bread and butter. These are the slightly different characteristics depending on how quickly the liver failure presents, whether it's hyperacute, acute or subacute. And you can see renal failure is more common in acute and subacute. It happens late. Ascites tends not to happen in acute and hyperacute. The subacute is almost behaving more like chronic liver disease. But the significant thing is the outcomes. And you can see in hyperacute, the outcomes are okay. But by acute and subacute, the outcomes are pretty poor. And part of that is the longer it takes, the sicker the patient gets, and it's harder then to rally them even if you do manage to get a good liver. Why do people get liver failure? Well, there's a big geographical variation depending on where you live. If if I just zoom in on why people get it in the UK, not surprisingly, it's mostly due to paracetamol, and following on from that, viral infections, not necessarily hepatitis viruses, a lot of seronegative viruses, and probably more of those that we just can't identify. Here's just another graph that looked at why people get it in the US, and it's very similar. It's mostly paracetamol, but drugs are the other thing that obviously you need to consider, and it's definitely there as a common cause. When you look at drugs, what drugs do it? Loads. These are the common ones. These are the uncommon ones, and I'm sure there's more. This is a slide that I expect you to take in all the details of, and I'll quiz you at the end because it's very straightforward. But this is looking at people, it's an American series looking from 1987 to 2006. And these are the groups of drugs that have caused acute liver failure that lead to transplantation, excluding paracetamol. So once you get rid of paracetamol, it's looking at these. So NSAIDs, statins, antibiotics, anticonvulsants, antituberculous medication, and a whole host of others. So lots of these that you'll be using on a day-to-day basis, and mostly very safely. Viral causes, here's the common ones. There's going to be a lot more, and there's a lot that we just don't identify. Any ideas? Yes, well said. Or death cap mushroom is also referred to. So other things, pregnancy-related liver failure, again very uncommon, but can happen. The medical student's favourite, Wilson's disease. Autoimmune hepatitis can be very difficult because that falls into the sort of acute, subacute timescale. And you have enough time to sort of fill in with enough steroids that you make transplantation very difficult, and they do that much worse by the time they get there. There was a nice review, if anyone's interested, in The Lancet in 2010, done by the guys who worked on the liver ITU at King's. And Will Burnell was the first author of that. And it gives a nice idea of what happens in acute liver failure. And essentially, it's a huge systemic response that affects pretty much every organ in the body. And actually, regardless of the etiology of the liver failure, you can have very similar progression, very similar effects affecting various different organs. The important thing when managing these patients is trying to determine the diagnosis, because the diagnosis determines the prognosis, and the diagnosis pretty much determines whether you're going to have a hyperacute liver failure, whether you're going to have an acute liver failure or a subacute liver failure. It's very rare that you'll need to biopsy patients with acute liver failure. Mostly, particularly if it's something like paracetamol overdose, you will just see a lot of hepatic necrosis, and it won't give you any diagnostic information. And bearing in mind they're going to have coagulopathy, and it's going to be a more risky thing. So history taking, as we're always taught, is incredibly important. By the time someone gets encephalopathic, that's bad news, and they shouldn't still be in Liverpool. Or not until we get a transplant centre anyway, which won't be for a long time if it ever happens. But if you assess it early and you assess it appropriately, you know when to pick up the phone to the transplant centre and get them to the appropriate place. It's a whole host of different groups of patients. There's loads of etiologies, but the process of the disease is very similar. There is no treatment that's going to work for acute liver failure as a whole. Steroids won't help unless there's specific etiologies that suggest it might. It's a rapidly progressive multi-organ failure, and it can be unpredictable. You know, the things you need to keep an eye on, you need to check for encephalopathy. What grade of encephalopathy do you think we generally pick it up at? Clinical assessment for encephalopathy, asking patients to hold their hands out and cock their wrists back. What grade of encephalopathy is that? 2, yeah. But actually, if someone's getting sick very quickly, you want to pick it up earlier than that. And so that's what you have to remember, what you've learned, and go around and give them a piece of paper and ask them to draw a 5-pointed star or a clock face with numbers around it. and just see if there's subtle things like that. Speak to their family, see whether or not they're wrong. You need to look for these things so you can make decisions early, because if someone is going down that cascade, the only thing that's going to help is liver transplant, and they really need to be determined whether they're appropriate for transplant and looked after in a place where transplant's an option. The initial management is standard intensive and supportive care. You need to speak to your ITU colleagues so that they will help out. You really need to speak to your local hepatologist or gastroenterologist who are going to look after it. Apart from anything else, they may not do much acutely, but if the patient gets to the transplant centre, if they get their transplant, they're the ones going to be helping look after them for the remainder of their life. And if they get the call afterwards from Leeds or Birmingham saying, can you take this patient back? And they say, who? It's a bit of egg on your face. Depending on the cause, there may be things you can do to help. So if it's a paracetamol overdose, and most of them are, don't forget the staggered overdose in the relatively underweight person as well, with a normal paracetamol level. If there's any doubt, give them an acetylcysteine, it won't hurt. And if they have got liver failure, keep it going longer than the standard antidote, 3 bags full. You want to keep it going until the INR falls back down to below 1.5 if they get significant liver dysfunction. If they've got a very aggressive autoimmune hepatitis that's going to give them a subacute liver failure, you need to give steroids, and that may give in big doses of steroids, 1.5 grams of methylpred every day for a few days. If you're doing that, you need to be in very close contact with a transplant centre, because if it doesn't work, they need to move. If someone's got acute viral hepatitis causing liver failure, you can give them antivirals. Traditionally, it was always lamivudine, tenofovir now probably be used instead. If it's herpes simplex related, acyclovir. But other than these, if you can pinpoint the actual cause, it's generic supportive treatment with ITU support. Encephalopathy we've talked a bit about, but the worry about encephalopathy is it's a sign of people starting to develop cerebral edema. And high intracranial pressure is what kills people. If they get to this stage, they need to be in a transplant centre. You need to be considering how you're going to monitor them. And reverse jugular lines or cerebral bolts are something that most ITUs wouldn't be particularly happy with and shouldn't be. It needs to be places that can then do something about it if it is a problem. If you get encephalopathy and you're not transplanted, the chances are you're not going to survive. So whoever said grade 2 for Asterixis, they were right. Encephalopathy and edema arise in inflammatory states anyway. There's a big role of infection here. These guys are very prone for opportunistic infections, and even in these days of strong antibiotic stewardship, it's very difficult to justify not putting someone with a significant liver failure, particularly related to paracetamol, but mostly that's where the data is. But I think acute liver failure in general, they need to be on antibiotics and antifungals, because a fungal infection is also an issue. They may well need sedating. You actually might want to run them hypertonic, hypernatremic, but again, this isn't something we should be doing outside of transplant centres. ALT, useful. Well, it won't tell you how the liver's doing. It might tell you why they've got liver failure. If it's very high, it's paracetamol, ischemia, or viruses. But an ALT of 20,000 doesn't mean the liver's failing. It means it's had a significant liver injury. A fall in ALT is not reassuring, and that's the take-home message here. Those who are old enough to remember using cardiac enzymes, CK and AST, will know that the AST always went up and fell down, regardless of how big the MI was. And the same is true if you have a liver infarct. The ALT will go up and it will come down, but the liver may still fail. And actually, it's a prothrombin time you need to be monitoring. That's what's going to tell you what's happening. Don't be afraid to give vitamin K. If the liver's failing, vitamin K won't make a difference. It may correct any dietary deficiency they have. But FFP will, because you're giving them clotting factors. And if you give clotting factors, you will mask what's happening to the prothrombin time. And you will also potentially reassure yourself or reassure the transplant centre that you're liaising with that the patient's not as sick as they are, and you may miss a window of opportunity. If they need procedures and things doing and need supporting, then this all needs to be done having liaised with your transplant centre and preferably there. So liver transplant. I should have asked you to give me a photo actually, Hassan, of someone carrying a liver. I couldn't find a decent one on Google. Anyway, I suppose that was fine. Transplantation is really the big thing that's made the difference for acute liver failure. It has transformed survival. Patients who have liver transplant for acute liver failure don't do as well as those who have elective transplants for chronic liver disease, because generally they're very, very sick by the time they have it, rather than just very sick. But they're acutely very unwell. They have multi-organ failure with sepsis. And once they meet King's College criteria, and you may have noticed the references I've used have almost universally come from John O'Grady at King's, who's written the vast bulk of the literature about this. They've set the criteria of who should be transplanted, and if you meet that and you're untransplanted, it comes back to this 15% survival. So what is the King's criteria now? Over 25 years old. It's related to coagulopathy or encephalopathy, and then if there's other factors as well, that may probe you in the direction that you need to be transplanted. Now these are when you need to be transplanted, not referred, so don't be afraid of referring earlier. If you make the call by the time they tick these boxes, it might be too late. They won't mind if they know about, actually the transplant centres prefer to know about people early, because they can always know about them and be stood down, but be aware that they may need to try and make it better if someone's getting rapidly sick. Do you all know how organs are allocated on the transplant list, if people are on the transplant list? People are scored according to the traditionally MELD in this country, UKEL, which is the end-stage liver disease score, and those with the highest score rise to the top, not surprisingly. If you have acute liver failure and you need a transplant, you get listed super urgently and you go right to the top of the list, and the next liver available nationally becomes yours. And everyone else just waits that bit longer. So get in touch early. If they get that sick, they will be transplanted early, because everyone else can afford to wait that bit longer. These are some more referral guidelines just for a bit of advice. Obviously it varies depending on how long, this is the paracetamol, how long after the paracetamol overdose, and obviously the categories change, but generally if you've got acidosis, coagulopathy, creatinine or encephalopathy, you need to be there. It's just the different degrees. And again, this is just using the hyperacute, acute and subacute classifications. Does transplant work? It does work and the outcomes are getting better. And this graph just shows the outcomes following transplant for acute liver failure in Europe from 1984 up until about 2008. And you can see the survival curves improving all the time with better peri-transplant care. So to summarise, acute liver failure is a very rare condition. It happens between 1 and 6 cases per million population per year. So it's not something you're going to see regularly, if at all. But it's important to know about because it carries a very high morbidity and mortality. It's important to recognise it early, and you need to find out why they've got it, or try and find out why they've got it, because that's what's going to make a big difference, and that's going to determine how quickly things are going to progress and how quickly you need to evaluate things. Don't be reassured by a falling ALT. It doesn't tell you that the liver's getting better. You need to repeatedly assess for early signs of encephalopathy, as I mentioned. You need to give antimicrobials, both antibiotics and antifungals. At Aintree, our antibiotic policy does include this. I can't talk about other units particularly. Get your guys involved early who are going to have to look after them afterwards, because they may actually be able to give some useful advice, but they're also going to have to pick up pieces down the line. Get your critical care team involved early and inform your transplant centre early. Any questions?
Two brief questions. One, why is it that paracetamol overdose is common in UK, but not in France? Do you have any explanation for that?
The question is, why is paracetamol overdose common in the UK and not France? I think it may actually be that those are proportions rather than absolute numbers, and that there's a higher viral burden in France and also Europe than in the UK, and that actually the proportions are that much smaller. Are the absolute numbers of paracetamol overdoses and liver failure smaller in France? I don't know the answer to that.
The second question is, use of steroids in alcohol hepatitis.
Yes.
I don't understand the question now.
Steroids and alcoholic hepatitis, there have been a whole load of studies that have shown very poor results and very little in severe alcoholic hepatitis. So if you calculate the Maddrey score and it's greater than 32, the STOPPER study is a multi-centre study that's taken place in the UK until recently. And actually, if you join together the Liverpool hospitals, we were the highest recruiters because we have a lot of alcoholic hepatitis here. It's not been published in full, but the results were presented at, I think, Basel last year, and they suggested a very modest improvement with steroids, but only just reached statistical significance. So I think we're never going to get anything better. There was over 1,000 patients randomised to 4 different groups looking at placebo, prednisolone alone, pentoxifylline alone, and pentoxifylline plus prednisolone. And I don't think there's any huge advantage to anything else. I think what it may show, and I've not seen the results of this yet, is actually the mortality from acute severe alcoholic hepatitis is less than previously reported, and I think we're actually better at managing the patient around it. We support them nutritionally, we look out for infections, we treat early, we look out for bleeds, we do these other supportive things. My personal feeling is the quantum of benefit from that is going to be greater than steroids, and there's always the risk of steroids if they're septic, if they're bleeding anyway. But from STOPPER it sounds like it may show a marginal benefit. I'm not convinced we need to start it straight away, because some patients will get better on their own, but I still use steroids if they're not settling. I guess the other thing to look at then is whether they respond to steroids, and there's reasonable data that if 7 days in the bilirubin is not falling, stop the steroids because they're not helping. I was updating my car tax online yesterday, and you don't get a tax disc anymore, but it does give you a link to the organ donor register when you do it. Okay.